Health is a state subject, but a lot of funding for health project is granted through central government, which means center has a lot of leverage over how state design their healthcare policies. This in turn can lead to several state-center coordination issues. Today, I have with me Ms. Sujatha Rao. Ms. Rao served as Union Secretary, Ministry of Health and Family Welfare. During her tenure, she launched first ever national program for non-communicable diseases. Prior to this, she worked as the Director General of National AIDS Control Organization, where she played a crucial role in establishing the systems and upgrading the organization. Today, we'll talk about state-center coordination issues with her based on her experience in Indian bureaucracy. Welcome, Ms. Rao.
Thank you for having me.
So, in a recent article regarding the problem of dengue in Delhi, you expressed your concern about center-state coordination issues in the public health sector of India. What are the major coordination issues that you observed during your stint in the Indian bureaucracy?
As you mentioned in your opening remarks, that as per the Constitution, health is a state subject. But as you also know, that there is a concurrent list and there is a union list, and health does figure in the concurrent list, which means both center and state have equal responsibilities. But the subjects are demarcated, what is in the state and what is in the concurrent. And infectious diseases comes under the concurrent list, largely because of the several externalities that infectious diseases entail. So in the case of dengue, the central government had as much a responsibility to ensure that it is controlled and contained and measures, preventive measures are taken well in time. That the center cannot just be critical of the state, it also ought to have been a bit more aggressive partner if they found the state was not doing its bit, and alerted them and got things moving well in time so that the epidemic wouldn't have unfolded the way it did.
So, how at the policy level these challenges can be addressed?
See, the challenges are, it's very challenging because the state really spends 70% of the total funding, that public financing, and the center's role is about 30%, which used to be much lower. It used to be 17, it's now gone up to 30. But still, it's a central government which has really been laying down policies. That has been the historical legacy that we have right from the time when we got independence. The center had a much more greater say in policy making with the states, and that was largely because the states never had enough fiscal space to really take the responsibility of providing service delivery at the state level. And for many things, many critical gaps, they depended on the center. So but the implementation is done by the state governments. The whole tension at the center state would be the center is laying down a certain policy, is willing to share resources. It used to be 50% of a particular program, say malaria control or TB control. Later it was enhanced to 100% assistance under several key components of the program. HIV/AIDS was 100% centrally assisted program. Like that, there were different proportions of funding that central government was giving, and it would obviously lay down the policy to be implemented. And every state had its own problems of being able to achieve those goals. So it meant a lot of negotiation, a lot of persuasion, a lot of dialogue with the states to get them to come on board and give priority to the programs that the central government wanted to push through. So it really is both a political, fiscal, and also a programmatic issue, because every state had its own capacities to reach the standards that the center was putting down very often.
I'm talking about your stint at NACO. You served as Director General, which is a part of Ministry of Health and Family Welfare. Can you share with us the key challenges that you faced and how you overcame them during the AIDS control program at NACO?
The time when I took over, India was on the defense. Internationally, it was under great pressure, being accused and alleged of denial of the HIV epidemic. There were estimations being done abroad that we would end up with about 25 million cases of HIV if we neglected the program anymore. At that time, our estimates showed we had about 5 million HIV cases. So it was at that moment when India was really on the defensive that I was posted as Director General, and I faced three major problems. My task was I have to reverse the epidemic, I have to contain it, and the task was also to then therefore to achieve that goal, scale up the program manifold. We had just a World Bank program, and with all the resources put in, our budget for the second phase of the NACP program was say about $500 million. But when we did a costed exercise of all the interventions that we wanted to do for scaling up the program, in order to achieve the reversal that was laid down as our goal, we came up with an estimate like $2.5 billion. That is a five-fold increase. So how do you make in those 5 years span states to absorb a five-fold increase in the budget and implement and design the interventions and implement them? So the main three basic challenges I had was building the organizational capacity, the central and the state and the district level, scale up so that the scale up in terms of physical access could be achieved. To fight a lot of, as you know, in HIV is really spread due to heterosexual and multi-partner sexual activities, which was about 98% the cause for the spread of HIV, which really meant that the target groups that we had to work with were all stigmatized and discriminated and criminalized by our laws, sex workers, men who have sex with men and drug addicts. So working with these groups was a very, very tough challenge because social consent wasn't there for working with them, and yet as a program we had to work with them in order to achieve the reversal in the epidemic. And the third was financial absorption. I mean, I can provide the money, but the pipes were all clogged at the state level. There was just no way money could have been absorbed unless and until we cleaned up each clog systematically, and that's what we did.
NACO project required you to manage multiple stakeholders. How did you manage to do it?
Oh, it was a tough challenge. First block of stakeholders were the donors. We had 29 donors. So we had a committee where all the donors, I would meet them periodically. But then ultimately I realized that of them there were really 6 or 7 major players. In fact, what I told them was either you should have ideas or you should have money to be involved with NACO, because I don't have time to run after every tiny donor working in some village. So we had basically Bill and Melinda Gates Foundation, for example, had $250 million project working in 84 sites. So they were a large donor, a big partner for us and a valuable one. And then we had the whole UN group and then DFID and USAID and so on. So they were very critical donors for us because they brought ideas and they brought the money too. And then we had the other stakeholders, or the state governments, which were the principal actors. They were really implementing the program. And more importantly were the sex workers and the homosexual community and the drug addicts, and then the third was the civil society organizations. And then we also had to work horizontally. This is within the program, vertical. But horizontally, we had to work with all the ministries because HIV, you could not just make it into a health issue. It had to go across to other departments. And if you were there around at that time, you'd find almost every ministry had hoardings on HIV/AIDS all over, because it was just not only a question of transmission, but it also meant reducing stigma and discrimination, which was really killing a lot of people. You could get HIV due to blood transfusion, and then you don't know why it has happened, and committing suicide. These were kind of the fear that was generated. So we had to work with reaching out and disseminating with a large number of people by using the other departments. And then we had the doctor community, which was, for PPTCT, that's the pregnant women HIV protection programs. We had to work with the gynecology and obstetrics department, for children with HIV with the pediatrics department, for HIV treatment alone with the medical department. So it meant working with institutions both in the public and the private sector who were providing ART treatment. So it was a huge task. But we brought all these people through the mechanism of technical resource groups. So we had 18 technical resource groups for each aspect of the program. And in this were donors, public sector, private sector, the communities most affected, the people living with HIV/AIDS, for example, were a very, very important stakeholder for us. And depending on what the group was about, the subject, we had NGOs, civil society, everybody was a member of that. Many of the TRGs I was chair. In many others, we had professionals chairing them. And this is how every guideline, every policy that we formulated would have to be based on the ideas and feedback we get from this group, and also screened and approved by them before we would take it up. So there was a concurrent dialogue and concurrent consensus building going on alongside. It was not like we make a policy and then you follow. So it was right from the beginning. So, we used to have drug addicts fight with us, walk out of meetings, things like this. So, but we had to get everybody on board. So it was a very fascinating challenge, yes.
Right. Finally, you revived the country's primary healthcare system by employing concepts such as result-based resource allocation. In relation to this, can you talk a little bit about the problem of accountability in public sector health services and how result-based financing tries to fix it?
Well, that's a very big statement. You said that I was reviving the primary healthcare system. No, I think that's too much. There was already, when I became Secretary Health, there was already the NRHM program, which was designed and articulated to revive the primary healthcare system in rural areas. And they already had performance-based, they were experimenting with new ideas of financing, like the Janani Suraksha Yojana was basically a cash transfer. And then they had another performance-based financing mechanism through which the health workers would be paid in accordance with the work being done for them. So if they brought a pregnant woman to a hospital for delivery, she would be paid 600 rupees. If she gave immunization to a child, she'd be paid something else. Like that, there were different rates. And that was the idea, was that you work, you get paid. And so you evaluate what kind of work they were doing. But when I became secretary and I looked at data, I found that we tended to distribute our budget across all facilities on an equal manner, Right. So there were sub-centers would get, say, 10,000 rupees as untied grant for meeting their immediate expenditures. A primary healthcare center would get 100,000 rupees. A community health center would get, or a district hospital would get, say, 500,000 rupees. And, all of them. But all facilities were not doing the same, carrying the same load of patients, inpatient, outpatients, or doing the outturn was not the same. So in my field visits, I realized, for example, a sub-center was doing 70 deliveries because they were a very motivated team, whereas the primary healthcare center barely got 10 footfalls. So why should the primary healthcare center be getting 10 times more money and other facilities when the real work was being done by a sub-center, which was just getting 10,000 rupees, is when they needed much more, because they needed, if they had such a big caseload of 70 deliveries a month. So that is what really then later gave rise to JSSK, because a lot of mapping was done, and we found that out of the 175,000 units that we have facilities, where we were giving equal budgets for, say, conducting institutional deliveries, when we did the mapping, it came down to about 18,000. So 18,000 units where 90% of institutional deliveries are being conducted, definitely then would be the foci for putting all your budgets over there rather than spreading them thin, including budgets, including training, including other requirements to ensure that these 18,000 are capable of handling this 80-90%. So if you really look at the whole approach, taking evidence and data into view, then planning becomes, and resource allocations become more rationalized and easier, because then you go where the need is, not that you establish the financial structures and then say now deliver the need. Right. So this follows the need.
Thank you so much for joining us. Today we discussed center and state coordination issues, where Ms. Rao brought out the fact that center and state are not able to work in tandem because of fiscal and political constraints. It also became clear from our work at NACO that for the success of a project, all stakeholders have to come together and work towards a common goal. This perhaps is also the key for the success of state-center coordination.